Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 428 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, GTJ, a 58-year-old man with non-resectable head and neck cancer, is being treated with cisplatin 100 mg per meter squared IV on day 1 and fluorouracil 1 gram per meter squared per day IV on days 1 to 4. He received 1 liter of normal saline before and 1 liter of normal saline after his cisplatin on day 1. He presents today for the third cycle of this regimen. GTJ's labs reveal an estimated creatinine clearance of 75 ml per minute, decreased from 110 ml per minute at baseline. Other abnormalities include serum magnesium of 1.2 milliequivalents per liter. All other electrolyte values are within normal range. So my question to you reads, is cisplatin responsible for GTJ's decreased glomerular filtration rate and serum magnesium levels? Cisplatin, a platinum heavy metal complex, is active against many solid tumors and remains as part of first-line therapy for lung, head and neck, and testicular cancers. The major dose-limiting toxicity of cisplatin is nephrotoxicity, and various renal and electrolyte disorders, both acute and chronic, have been associated with cisplatin. In the early 1970s, before the need for vigorous hydration was recognized, cisplatin often caused acute renal failure. Today, with the use of vigorous hydration, acute renal failure is uncommon. However, tubular dysfunction and decreased glomerular filtration rate remain problematic. Morphologic damage is greatest in the straight segment of the proximal renal tubules where the highest concentration of platinum occurs. Acute and cumulative renal tubular damage has been demonstrated by increased urinary excretion of proximal tubular enzymes, such as beta-2 microglobulin, alanine aminopeptidase, and acetylglucosamine. Acute renal failure occurs from acute proximal tubular damage and presents as polyuria in the first 24 to 48 hours when urine osmolality declines, but glomerular filtration rate is normal. Polyuria will decline, and then 72 to 96 hours later polyuria increases again, urine osmolality declines, and the glomerular filtration rate declines as well and is persistent. Increases in proximal tubular enzymes correlate well with urinary excretion of protein and magnesium as well as decreased reabsorption of salt and water in the proximal tubules. GTJ has hypomagnesemia, which is the most common electrolyte abnormality caused by cisplatin. Hypomagnesemia appears to be dose-related and may occur after a single treatment. Despite replacement with oral magnesium, renal losses of magnesium and decreased serum magnesium levels can persist for months or even years after completion of cisplatin therapy. Hypercalcemia, hyponatremia, and hyperkalemia occur less frequently. The cause of these electrolyte abnormalities is thought to be similar to that of hypomagnesemia in that a proximal tubular defect occurs that interferes with reabsorption of these electrolytes. Chronic renal toxicity associated with cisplatin presents as a decrease in the glomerular filtration rate. Published reports suggest that the glomerular filtration rate decreases by 12% to 25% in most patients receiving multiple courses. The decrease appears to be persistent and only partially reversible. An increase in serum creatinine or a decrease in creatinine clearance does not necessarily reflect the decline in glomerular filtration rate. GTJ is at risk for chronic renal toxicity because he has previously received 2 other cycles. The renal function of patients receiving cisplatin therapy should be evaluated, because dosage reductions of cisplatin may be necessary if the creatinine clearance decreases. GTJ's decreased glomerular filtration rate and low serum magnesium likely are caused by repeated cycles of cisplatin therapy. Although a dose reduction of cisplatin generally is not recommended for creatinine clearances that are greater than 60 ml per minute, the clinician should provide GTJ with adequate and aggressive hydration to prevent cisplatin nephrotoxicity. Despite preventive methods, many patients will still experience declines in glomerular filtration rate as seen in GTJ. In addition, GTJ should receive an oral magnesium supplement. When large doses of magnesium are necessary, diarrhea often limits the use of oral supplementation. IV administration should be used if higher magnesium doses are required. Patients should undergo frequent measurements of their electrolytes, including magnesium, to minimize potential complications. My next question to you reads: what measures should be taken to prevent further cisplatin nephrotoxicity in GTJ? Several measures are used to minimize or prevent cisplatin-induced nephrotoxicity, including hydration with saline and prophylactic magnesium. Incorporation of hydration with saline and magnesium is the standard of care for all patients receiving cisplatin. The patient should be vigorously hydrated with 2 to 3 liters of normal saline over 8 to 12 hours to maintain a urine output of 100 to 200 milliliters per hour for at least 6 hours after treatment with cisplatin. A loop diuretic, e.g., furosemide, may be required in elderly patients to eliminate excess sodium or in patients with compromised cardiac reserve. But these diuretics should not be used routinely to prevent nephrotoxicity. Additionally, mannitol, dosed at 25 to 50 grams, may be administered just before chemotherapy to prevent cisplatin-induced renal artery vasoconstriction, which can increase the concentration of platinum in the renal tubules. The use of mannitol is controversial and is not given in all practice settings. Most patients may also benefit from prophylactic magnesium supplementation. Patients who received prophylactic magnesium 16 milliequivalents IV daily during a 5-day course of cisplatin followed by 60 milliequivalents orally, dosed at 20 milliequivalents 3 times daily, between courses experienced less nephrotoxicity compared with those who received no supplements in a prospective trial of 16 patients with testicular carcinoma. GTJ should be encouraged to increase his oral hydration to 2 to 3 liters per day for several days after this cycle of chemotherapy. Additionally, he should take oral magnesium supplementation between courses. For cycle 4 of his chemotherapy, he should receive 3 to 4 liters of saline the day of cisplatin administration. He may also receive 25 to 50 grams of IV mannitol before cisplatin to reduce his risk of further nephrotoxicity. Patients who experience renal dysfunction commonly have the dose of cisplatin reduced. Guidelines to modify the dosage of cisplatin in patients with decreased renal function are available. Most suggest a 50% dosage reduction when the glomerular filtration rate decreases to 30 to 60 ml per minute and discontinuation when the glomerular filtration rate falls to less than 10 to 30 ml per minute. Percentage dose reductions are relative to the recommended dose for a specific cancer in a given combination chemotherapy regimen. Because the cisplatin dose ranges from 50 to 120 mg per meter squared, the precise dose for a patient with a glomerular filtration rate of less than 60 ml per minute must be individualized to the situation. GTJ should have another serum creatinine drawn to estimate creatinine clearance before his next cycle. As long as his creatinine clearance is maintained above 60 ml per minute, then no dose reductions of his cisplatin are necessary. If a tumor type is known to be responsive to carboplatin and efficacy will not likely be compromised, substitution of carboplatin should be considered because it does not cause nephrotoxicity. Carboplatin is excreted primarily by the kidneys, and the dose is calculated by the Calvert equation, which accounts for decreased glomerular filtration rate. Therefore, patients who have decreased renal function receive lower doses than those with normal function. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 429.